Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is about hemostasis and the medications that affect hemostasis, and this is part 5 of pharmacology for nurses. The learning objectives for this are to review hemostasis physiology, platelet inhibitors, anticoagulants, fibrinolytics, anti-fibrinolytics, anti-hemorrhagics, and then see what you've gained at the end of this learn shop in a knowledge review. Right, when we look at platelet aggregation, what does that mean? Well, platelets clumping or aggregating, this is the process by which platelets adhere to each other at sites of potentially a vascular injury, and it's long been recognized as a critical component for a hemostatic plug to form and eventually form a thrombosis and eventually a fibrin thrombosis. There are many common substances that can activate platelets through a common pathway, and this results in glycoprotein receptor 2B 3A activation, fibrin. Now, the coagulation pathway can be either extrinsic or intrinsic. The extrinsic pathway for blood coagulation is also known as the tissue factor pathway, and it refers to a cascade of enzymatic reactions resulting in blood clotting in conjunction with injured tissue cells. This is the extravascular tissue factor. Looking at the diagram, damage to the tissue outside the blood vessel. This results in the release of tissue thromboplastin, which activates inactive factor X, activates it, which activates prothrombin to thrombin in conjunction with fibrinogen, fibrin, and eventually factor 8, which creates a blood clot. Now, the intrinsic pathway has got all the same required clotting reactants in the circulation. However, it's activated through trauma and the exposure of endothelial collagen. And this is inside the blood vessel. So, looking at the diagram, you've got damage to the blood vessel, and this causes a cascade of the clotting factors. It activates factor X, which again activates prothrombin to thrombin, fibrinogen to fibrin, and factor 8 to eventually get a blood clot. Now, with coagulation, it's the fibrin clot that's really important. And fibrin is also known as factor 1. And this is a protein. And it's formed by the action of the protease, thrombin, on fibrinogen. The fibrin together with platelets form a hemostatic plug or a thrombus or a clot. So therefore the fibrin clot or thrombus in conjunction with calcium is very important. Calcium is the link for all the factors to eventually form the blood clot. Fibrinolysis is another important process we need to understand. Physiological fibrinolysis occurs in everybody naturally. This is when endothelial cells secrete tissue plasminogen activator. And this converts inert inactive plasminogen to active plasmin, which binds to a fibrin clot. And it dissolves it. So fibrinolysis is breaking down of the fibrin clot, because you don't want fibrin clot to be ongoing. You're going to end up with now thrombi throughout the whole body. So the blood clot induces secretion of tissue plasminogen activator from endothelial cells. The tissue plasminogen activator activates plasminogen and converts it to plasmin. And plasmin liaises or comes in contact with a blood clot, fibrin, and begins the process of dissolving it. Fibrinolysis. When we look at certain components related to clotting, we have what are called platelet inhibitors. And these are medications that prevent thrombogenesis. We have thromboxane 2 platelet inhibitors, ADENODIPHOSPHATE platelet inhibitors, glycoprotein 2B3A platelet inhibitors. We have anti-thrombin 3 inhibitors, prothrombin inhibitors, fibrinolytics, and thrombolytics, which we'll be looking at as we go through. Now, when we look at thromboxane 2 platelet inhibitors, the most common one is acetylsalicylic acid, or aspirin. And the action is to inhibit thromboxane. It also has an anti-inflammatory effect through its anti-C-reactive protein. It's also a prostacyclin vascular inhibitor. It can stop pain. Typically the dose is 81 to 300 milligrams per day, and the indications are for stroke, atrial fibrillation, which could cause stroke, angina, acute myocardial infarction after post-AMI, and post-coronary artery bypass graft surgery, because it inhibits platelets and thrombosis. The major adverse effects, however, are that you can bleed, and you may end up having allergic reactions. But it's a very useful medication. Then you've got adenodiphosphate, ADP, platelet inhibitors, clopidogrel, or Plavix, which is a very expensive medication. And it inhibits binding of ADP to the platelet receptors, which is important for clotting. It prevents glycoprotein 2B3A receptor activation, fibrinogen. The typical dose is 75 milligrams per day, and the indications are the same as previously: stroke, atrial fibrillation, post-acute myocardial infarction, angina, post-percutaneous transluminal coronary angioplasty or stenting, and post-coronary artery bypass graft surgery. The major adverse effects, however, are hemorrhage. Then you have glycoprotein 2B3A platelet inhibitors. And I can never pronounce the ABC iximab. I'll just call it repro. The action is to inhibit platelet binding to fibrinogen and von Willebrand factor. And the dose is typically 0.25 milligrams per kg over 10 to 60 minutes prior to percutaneous coronary interventions. Then an infusion, then maintenance, and the maintenance is given at 0.125 micrograms per kilogram per minute for about 24 hours. The indications are post-percutaneous transluminal coronary angioplasty and associated stenting that's performed. The major adverse effects are hemorrhage. Another one is tirofiban, also called aggrastat, as a platelet inhibitor. And this one inhibits platelet binding to collagen, fibrinogen, and von Willebrand factor, and it's given according to weight. Typically 0.04 micrograms per kg per minute for about 30 minutes, and then for the next 24 hours at 0.1 microgram per kilogram per minute. Also post PDCA and stenting, and the major adverse effect is hemorrhage. The next group are anti-thrombin 3 inhibitors. And most of us are familiar with heparin, sodium heparin, also known as Heplock. And it enhances anti-thrombin 3 secretion by about 1,000 times. It has a direct antiplatelet effect, and it binds to and inhibits 1 Willebrand factor. Loading is typically 50 to 100 units per kg, with a maintenance infusion about 10 to 25 units per kg per hour, and it's adjusted according to your APTT, your activated partial thromboplastin time. And typically it's 1.5 to 2.5 by control. The indications are any risk for thrombosis development, which could be deep vein thrombosis, pulmonary embolism as prophylaxis, or post-percutaneous coronary interventions such as percutaneous transluminal coronary angioplasty and stenting. Again, the major adverse effects of heparin is hemorrhage or heparin-induced thrombotic thrombocytopenia syndrome. Heparin has got an antidote, which is always good to know. And the antidote or reversal of heparin is protamine sulfate 1%. And it's given intravenously 25 to 50 milligrams over 10 to 30 minutes. 1 milligram of protamine sulfate neutralizes 100 units of heparin. And always consider fresh frozen plasma because it's got all the clotting factors in it at 15 mils per kg. Now, prothrombin inhibitors include warfarin, also known as COUMADIN. And the action of warfarin is to inhibit vitamin K, therefore it prevents synthesis of prothrombin. And this is usually effective after about 72 hours after commencing the dose. The adult dose is typically 5 to 15 milligrams per day for 2 to 5 days before you become therapeutic. Then maintenance 2 to 10 milligrams per day according to your INR, your international normalized ratio. There is an adult dose and there is a pediatric dose. The indications are typically for deep vein thrombosis, pulmonary embolism, or stroke, which is ischemic. It can also be indicated for cardiac failure because, again, during cardiac failure, you have hypokinesis of the heart and a mural thrombosis risk can form in the ventricles and the atria. Atrial fibrillation, clots can form in the atria, or AV-dissociated rhythms like junctional rhythms, heart blocks. Also post-cardiac mechanical valve implantate surgery. The major adverse effects are hemorrhage and this time hemorrhagic stroke. So it's important to monitor the INR. Now, the INR has got a typical therapeutic range. The INR for 3 to 4.5 is typically reserved for prosthetic cardiac valve implants, recurrent deep vein thrombosis, or pulmonary emboli, myocardial infarction. An INR of 2 to 3 is for transient ischemic attacks, TIAs, intermittent strokes, or deep vein thrombosis and pulmonary emboli. The INR of 1.5 to 2 is reserved for complicated heart failure and atrial fibrillation. The longer your INR, the longer it takes for your blood to clot. It doesn't stop blood clotting, it just prolongs the coagulation cascade. 1.5 INR is shorter than an INR of 4.5. So therefore, if you have an INR of 4.5, you're at increased risk of bleeding. If you've got an INR of less than 1.5, you're at increased risk of developing a thrombosis. Now, for warfarin, there's an antidote. And the antidote is vitamin K. Vitamin K1, quinaquine, phytonadione. The adult dose is typically oral, subcutaneous, intramuscular, 2.5 to 10 milligrams. In pediatrics, 2 to 10 milligrams. But the maximum dose is age specific because you can have neonates, pediatrics that are toddlers or children. Also remember, consider fresh frozen plasma because it has all the required clotting factors at 15 mils per kg. Now when we look at fibrinolytics, they can also be called thrombolytics, but they're not really. A thrombosis can be a red thrombosis or it can be a white thrombosis. A white thrombosis is fibrin. A red thrombosis is developing. So when we look at fibrinolytics, we have got tissue plasminogen activator, rtPA or streptokinase, and they act in relation to plasminogen being converted to plasmin. And therefore, as a consequence of that, they interfere with the development of fibrin or they break down fibrin. rtPA, also known as ALTEPLASE, is a natural hemolytic enzyme that binds to fibrin. And it converts plasminogen to plasmin on the fibrin surface, and it's very clot selective. The standard dose is typically 100 milligrams, an initial bonus of 15 milligrams, and maintenance 50 milligrams over 30 minutes. The second maintenance dose 35 milligrams over an hour. Indications are ST elevation myocardial infarction, as long as it's within a 12-hour window, otherwise it won't be as effective. Or AV, atrioventricular fistula thrombosis, thrombosed mechanical cardiac valve implants, or a ischemic stroke with a 3-hour window. The major adverse effects are hemorrhage and hemorrhagic stroke. ALTEPLASE. Streptokinase, streptase. This is an enzyme that was harvested from the hemolytic streptococci bacterium, and it converts all contacted plasminogen to plasmin. It's not selective. The adult dose is typically 1.5 million units in 100 ml of normal saline over 30 to 60 minutes. In other forms of pathology, not ST segment elevation myocardial infarction, the dose is 250,000 to 600,000 units over 30 minutes. Pediatric dose, needless to say, is less. Indications are STEMI, ST segment elevation myocardial infarction within a 12-hour window, AV fistula thrombosis, thrombosed mechanical cardiac valve implants, and ischemic stroke within a 3-hour window. However, the major adverse effects include an anaphylactic reaction to the enzyme which comes from a bacterium, the hemolytic streptococci. Otherwise, other adverse effects are the same: hemorrhage and hemorrhagic stroke. When we look at anti-fibrinolytics, these are medications that stop the breakdown of fibrin. So therefore the patient or the person or the victim must be bleeding. And this is to stop bleeding. Aprotinin, traziolol, is an antifibrinolytic agent and inhibits plasminogen conversion to plasmin. The standard dose is about 2 million units over 30 minutes. It's indicated for problematic hemorrhage post-surgery, and it's an antidote for therapeutic fibrinolytic interventions, such as streptokinase, ALTEPLASE, and so on. The major effects are, if they're adverse, thrombosis. You don't really want to be causing clots everywhere, but you do want to decrease hemorrhage. You've also got desmopressin, DDAVP, and this raises plasma levels of von Willebrand factor and factor VIII. It's also an antidiuretic hormone, a vasopressor. Both adult and pediatric doses are the same, 0.3 micrograms per kg in 50 ml of saline over about 20 minutes. It can also be given intranasally, 2 to 4 micrograms per dose, twice a day. It can be used for diabetes insipidus as a consequence of antidiuretic hormone problems. Indications are to reduce postoperative bleeding. It's used in diabetic insipidus, and it can be used for haemophilia. The major adverse effect, however, is thrombosis. So let's review. Can you name 2 components that relate to hemostasis? The 2 components are thrombogenesis and fibrinolysis. And they are at constant loggerheads with each other, promoting clot formation and then breaking down the clot. Name the 2 medication groups that prolong and inhibit thrombogenesis. The 2 medication groups are platelet inhibitors, which prolong thrombogenesis, and anti-thrombin 3 medications that inhibit thrombogenesis. Name 1 platelet inhibitor and 1 major adverse effect of that medication that you've named. An example would be clopidogrel, hemorrhage, aspirin or acetylsalicylic acid, hemorrhage, aggrastat, tirofiban, hemorrhage. Name 1 antithrombin inhibitor and the recommended antidote. You can choose heparin, and the antidote is protamine sulfate, and consider fresh frozen plasma. You've got warfarin, the antidote is vitamin K, and consider fresh frozen plasma. Name 2 fibrinolytic medications and 1 major adverse effect of those medications. You've got streptokinase, an anaphylactic reaction. Yes, sure, bleeding as well. You've got ALTEPLASE or rtPA, hemorrhage. Thanks again, everyone, for your attendance. As I've said previously, if you find these of any benefit to you, please recommend them to your colleagues. Subscribe if you want to, and then review part 6, 7 and 8 of Pharmacology for Nurses on the YouTube channel. Thanks everybody. See you in the next Learn Shop.